This episode of Primary Care Pharmacology is all about beta blockers. Now, this is a pretty huge topic. There are a lot of different beta blockers and there's a lot of different things we use them for, so I'm just going to jump right in. As usual, we'll go through the same 6 sections: the formulae, indications, pharmacology, followed by practical day-to-day use of beta blockers, as well as contraindications and their side effects. Starting off now with the formulary. As you can see, there are a huge number of beta blockers, and it can be quite intimidating seeing this list and knowing where to begin. So, as I usually do, I think it would be a good idea to exclude those beta blockers that we very rarely use in primary care. The first ones I'm going to get rid of are these 3: betoxol, luvabunolol, and timolol. These preparations are exclusively used in ocular compounds, usually for the treatment of glaucoma, and generally started by secondary care eye clinics and not by us in primary care, so I won't mention these any further. The next drug I'm going to focus on is esmolol. This is a rapidly acting intravenously delivered beta blocker which is useful for the management of arrhythmia in anaesthesia, obviously completely irrelevant to us in primary care, and I shan't mention it again. The next 3 I'm going to get rid of is these 3. Now, these beta blockers have something that we call intrinsic sympathetic activity. This basically means that as well as being beta blockers, they're also partial beta agonists. Now, this is a useful effect in the control of certain side effects. However, I don't think I've ever seen one of these drugs actually used in clinical practice, and most of your local pharmacies will probably look at you blankly if you try and prescribe someone these, so I'm not going to talk about them any further. The last beta blocker I'm going to ignore is sotalol. This is a very old-fashioned beta blocker that is also an antiarrhythmic drug due to its effect on potassium channels. For that reason, it's generally something that should be started by cardiologists and not in primary care, so I'm not going to talk about it from here on. The remaining beta blockers we can divide into 2 groups: the cardioselective and the non-cardioselective beta blockers, and I've listed these here, giving us now 8 drugs, which hopefully should be more familiar to you. First, I want to talk a little bit more about the cardioselective beta blockers: nebivolol, bisoprolol, atenolol, and metoprolol. Now, of these 2, I pretty much exclusively use nebivolol and bisoprolol, and here's why. First, when we look at the degree of cardioselectivity, there are quite wide variations between these drugs, as well shown in this chart here. Atenolol isn't mentioned, but it's very equivalent to metoprolol, and unfortunately I couldn't find a graph that has all 4 drugs at once. As you can see, nebivolol is by far the most cardioselective of the beta blockers, followed by bisoprolol, with metoprolol and atenolol coming after them. None of these drugs is cardio-specific, and they will all have some degree of beta-2 effect, but if you want a cardioselective beta blocker, I think you're better off going with bisoprolol or nebivolol. In addition, nebivolol has some effect on beta-3 receptors that leads to nitric oxide-mediated vasodilation. This can be helpful in the management of certain side effects, although it doesn't seem to affect nebivolol's efficacy as a drug when compared to bisoprolol. Atenolol, on the other hand, is associated with some negative metabolic effects, particularly increase in insulin resistance and some adverse lipid profile changes, such as an increase in the LDL concentrations. It also is mildly anticholinergic and has an ACB score of 1. This is why, unless you've got a good reason to, I rarely use atenolol. Metoprolol is a totally decent beta blocker, but has been generally out of stock for quite some time, and most manufacturers no longer make this, so it's not very appropriate prescribing in the UK for the foreseeable future, and I can't think of the last time I've ever seen anyone use it. Among the non-cardioselective beta blockers, these pretty much can be separated into 2 groups. The first is propranolol and nadolol. These are very similar non-cardioselective beta blockers. Nadolol has a longer half-life than propranolol, but propranolol is commonly available in modified release preparations, which allow you to get around this. The big difference between them, however, is that propranolol has a special action. It inhibits the conversion of T4 to T3, making it very useful in the treatment of thyroid toxicosis. No other beta blocker has this effect, and that is why we always use propranolol when treating patients with overactive thyroids. The other group of non-cardioselective beta blockers is carvedilol and labetalol. As well as being beta blockers, these also have alpha blocking properties, which make them potent vasodilators and can be useful in the management of certain diseases. We'll come into that a bit more later when we go through practical use. Just to recap, the 8 beta blockers that we usually use in day practice are these, although you probably can ignore metoprolol because we can't get hold of that anymore. Next, I want to talk a bit about the indications of beta blockers, and there are loads. In fact, I could count 10 different common indications of beta blockers, but there are more, and this list isn't exhaustive. This is just the ones we tend to use them more regularly for. I'm going to go through these in a bit more detail, but first I think I need to talk a little bit about their pharmacology so I can explain why we use them and how it's helpful for our patients. Thinking back to medical school, you're probably already aware that there are 3 types of beta adrenoreceptors: beta 1, beta 2, and beta 3. Although beta 1 and 2 are by far the most important. Beta 1 adrenoreceptors are found both in the heart and in the kidney. By antagonizing these receptors through the use of beta blockers, we cause a reduction in the heart rate, a reduction in myocyte contractility, and a reduction in conduction velocity via the AV node. As well as this, you get reduced renin secretion in the kidney, which contributes to their antihypertensive effect. Beta 2 receptors are far more common and can be found in lots of different parts of the body, and I'm going to run through them very quickly here. You can find beta 2 receptors, as we well know, in the vasculature in the lungs, but also in the gut, the bladder, the uterus, the pancreas, the liver, and the eye. And I'm just going to talk through each one of these in turn to explain what beta blockers do. First of all, I'm going to talk about the vasculature. And here, use of beta blockers causes vessel constriction. Now, this may seem a bit counterintuitive. We generally think of adrenaline as causing vasoconstriction, so why does antagonism of adrenoreceptors do the same thing? And that all comes down to how our body regulates blood flow in a fight or flight response. Alpha adrenoreceptors will induce a vasoconstriction, but beta adrenoreceptors will cause a vasodilation. By having different ratios of these receptors at different parts of the body, we can divert blood supply to the key organs and muscle groups that would be needed in a fight or flight response. As a result, when you antagonize these beta adrenoreceptors, you get unopposed alpha adrenoreceptor mediated vasoconstriction. Thus, beta blockers cause vasoconstriction, and this is responsible for some of their side effects, such as peripheral coldness. I hope that all makes sense. The next organ I'm going to talk about are the lungs, and here we know that, again, adrenaline causes a bronchodilation to allow us to get more air in and out of our lungs. Hence, use of beta blockers causes a bronchoconstriction. This is important when thinking about exacerbation of asthma when asthmatics are given non-selective beta blockers. In the gut, use of beta blockers will increase intestinal peristalsis and gastric contraction. In the bladder, use of beta blockers will increase bladder wall contraction and give you unopposed alpha adrenoreceptor mediated sphincter contraction. In the pancreas and the liver, beta blocker use will cause increase in insulin resistance and a reduction in gluconeogenesis. In the uterus, beta blocker use can affect initiation and progression of labour, although I'll leave that to the obstetricians to consider as not really relevant to us in primary care. Lastly, in the eye, use of beta blockers will cause a reduction in the production of aqueous humour, hence their use in the treatment of glaucoma. Lastly, I just quickly want to mention beta 3 receptors, though as I did say earlier, these are less clinically relevant. You find beta 3 receptors in 2 places. One in fat cells, meaning that beta blocker use will cause a reduction in lipolysis and potentially an increase in weight gain. And you can also find them in the bladder, where use of beta blockers will cause an increase in bladder wall contraction. This doesn't have much clinical relevance, although beta 3 receptors are important in the control of overactive bladder syndrome, where they can be agonized with the use of mirabegron. But that is a video for another day. Next, I want to talk a bit about the practical use of beta blockers, and we're going to go back to that list of 10 common indications, and I can unfortunately see no other way than talking through these one by one and explaining what the current evidence is for beta blocker use and which beta blocker you should use. I'm going to start off with stable angina. Now, the European Society of Cardiology recommend that a beta blocker, either alone or in combination with a calcium channel blocker, should be your first-line anti-anginal for most patients. I couldn't find any evidence that one beta blocker is better than another, but I tend to use cardioselective beta blockers unless I've got another indication for the patient to be on one. I should point out that in vasospastic angina, Prinzmetal angina, beta blockers can actually exacerbate symptoms. I'm going to talk a little bit more about this in the contraindications later on, but just bear it in mind when you're choosing a patient's anti-anginal. Next, arrhythmia and palpitations. Now, this obviously very much depends on the underlying arrhythmia and underlying cause. And In any patient with palpitations, they need a full assessment, including an ECG and potentially cardiology involvement. Where beta blockers are appropriate, such as the rate control of atrial fibrillation, I couldn't find any evidence that any beta blocker was superior to any other, but again, I tend to use cardioselective beta blockers for this indication. For the secondary and prevention of myocardial infarction, beta blockers have long been a cornerstone of management. However, in recent times we're starting to reconsider their use. The data for use of beta blockers long term tends to come from very old studies, long before we had widespread use of PCI, and long before we understood the importance of optimizing cardiovascular health through the use of things such as statins. More recent studies have found that beta blocker use beyond 1 year following myocardial infarction doesn't seem to make any difference to the overall outcome. And little by little, guidelines are changing to reflect this. The most recent AHA guidelines have recommended that 1 year following an MI, beta blocker use should be reassessed and that it should be decided if it's still appropriate. And NICE gives similar recommendations to this. The European Society of Cardiology are due to release their new guidelines next year, and it's suspected that they will give similar advice. You should, of course, remember that patients with a reduced ejection fraction will benefit from long-term beta blocker therapy, and in these patients, you should usually continue them. Speaking of that, I'm next going to talk about heart failure with a reduced ejection fraction. Just to very quickly revise this, when I talk about ejection fraction, we now categorize heart failure into one of 3 groups. Heart failure with preserved ejection fraction, over 50%, heart failure with a mid-range or mildly reduced ejection fraction between 41 and 49%, and heart failure with a reduced ejection fraction, which is below 40%. The European Society of Cardiology recommends that in all patients with reduced ejection fraction, beta blockers should be given long-term as they provide both prognostic and symptomatic benefit. There does seem to be some evidence of use in a mid-range ejection fraction as well. However, in patients with a preserved ejection fraction, there was evidence that beta blockers actually increase the risk of hospitalization. And if you haven't got another indication for their use, these patients should not be given beta blockers. When you're choosing the beta blocker, there is specific evidence for carvedilol, bisoprolol, nebivolol, and metoprolol. And given that I always prefer drugs that are once daily dosed, I always give bisoprolol or nebivolol. The next topic is thyrotoxicosis. And I've already mentioned this earlier, that this is a situation where only propranolol will do. And the reason we use it is because it prevents conversion of T4 to the more biochemically active T3. Hence, it's very handy in the use of symptomatic thyrotoxicosis. Now, if your patient cannot take a non-selective beta blocker, usually because they're asthmatic, then rather than using a different type of beta blocker, you're probably better off using a different class of drug altogether, such as a rate-limiting calcium channel blocker like diltiazem. Of course, if you're not sure, you should consult an endocrinologist for advice on this. The next topic is hypertension. And we regularly still see patients being given atenolol to control this. And that's because previously it was the first-line antihypertensive, but this all changed back in 2006 following the publication of a Cochrane review that found that beta blockers were inferior to calcium channel blockers, renin-aldosterone angiotensin system inhibitors, and diuretics in stroke and cardiovascular disease prevention. As I mentioned earlier, this may have something to do with atenolol's negative metabolic effects. In most of the studies comparing these drugs, atenolol was used as the reference beta blocker, so it's unsurprising that they were found to be more effective in preventing cardiovascular negative outcomes. However, more recent research comparing more modern beta blockers such as carvedilol and nebivolol found similar inferiorities when compared to those previously mentioned other types of antihypertensive. For this reason, beta blockers are generally not used as a first-line antihypertensive, although of course they may be part of an overall hypertensive strategy in a patient who has other indications for beta blocker use. Where you are using a beta blocker, there doesn't seem to be a significant difference in the efficacy between the different drugs. Particularly thinking about nebivolol's additional vasodilatory effects, it doesn't seem to make it any better at reducing blood pressure than, for example, bisoprolol. Where beta blockers are commonly used is hypertension in pregnancy, and this all comes down to its established safety profile, in particular of labetalol, which makes it our first-line drug for most patients affected. If you've got patients with chronic hypertension who are at risk of pregnancy, then always remember that ACE inhibitors and A2RBs and thiazide diuretics are contraindicated in pregnancy. So any women who are thinking of becoming pregnant should usually be switched onto labetalol early on to prevent any negative outcomes as a result of this. I'm now going to talk a bit about portal hypertension, and of course these patients are generally under the care of a hepatologist. Usually you would need a non-selective beta blocker. Propranolol, nadolol or carvedilol are all good options. For anxiety, propranolol is widely used to treat the physical symptoms, although I should point out it's not in the NICE guidelines for anxiety. If you are going to use propranolol for this reason, it should be used in an immediate release form as and when needed to immediately treat symptoms. Please bear in mind that beta blockers are toxic in overdose, so if you're going to give someone with anxiety propranolol, make sure you clearly assess their risk of suicidal intent and be careful if you've got any concerns. Migraine prophylaxis, we most commonly use propranolol, and it does have by far the biggest evidence base. However, if you can't use a non-selective beta blocker, there is evidence for use of atenolol, metoprolol or bisoprolol in treating migraines. Lastly, essential tremor. And for essential tremor, only propranolol is licensed as treatment. However, if you can't take a non-cardioselective beta blocker, then I have found evidence that metoprolol or atenolol could also be used. I know that was an awful lot, so I'm just going to put up this summary slide here just to clarify which are the most commonly used beta blockers. If you need to, pause the video here. I'm not going to go through it all again. You'll be glad to hear. Next, we'll talk about the common contraindications for beta blockers. And by far the most commonly one we have to deal with is asthma. There is some confusion about this, so I'm going to clarify. Non-cardioselective beta blockers are associated with an increased risk of bronchospasm in asthmatics and should not be used, full stop. If you've got someone with asthma, do not give them propranolol, labetalol, carvedilol or nadolol. You are asking for trouble. Now, the use of cardioselective beta blockers is a bit more controversial, and it's actually substantial evidence that they're perfectly safe in mild to moderate asthma. There is some evidence that there is a very short-term reduction in the FEV1, which I mean less than 3 days, and for this reason I'd be very cautious in severe brittle asthmatics. I will point out that NICE guidelines contraindicate the use of all beta blockers in patients with obstructive respiratory disease, so always be cautious and if need take advice from a respiratory physician. COPD is a little bit different because by definition there's a degree of fixed airflow limitations, so therefore the use of beta blockers shouldn't make much of a difference. Historically, there's been concern that patients with COPD are being incorrectly denied beta blockers based on concern that they're going to exacerbate their respiratory symptoms. And as most patients with COPD are smokers, they often have coexistent cardiovascular disease and thus would benefit from beta blockers. The general consensus is for most patients, beta blockers are beneficial and the benefits far outweigh any risks. Of course, if you have a very severe COPD patient, you could always take advice from a respiratory physician. The next common contraindication is bradycardia, and of course, when we use a beta blocker, we're often trying to achieve a degree of bradycardia, or at least slowing down the tachycardia. You should generally try and keep a patient's heart rate above 50, and you should never use a beta blocker in someone with a second or third degree heart block. Some patients have the so-called tachybrady syndrome, where they will fluctuate between periods of tachycardia and bradycardia, and they should be referred to cardiology for consideration of pacemakers to allow adequate rate control. Next, I'm going to talk about vasospastic angina, and I did mention this earlier on. You may not have heard of this, but it's an increasingly recognised phenomenon, and it's classified alongside microvascular angina with the overall term of ischemia and non-obstructive coronary artery disease. Now, there are ways of trying to work out whether a patient has microvascular or vasospastic angina, but certainly my local cardiologists rarely do this, and you will often get someone referred for anginal type pain who has a normal angiogram simply discharged. For this reason, if you think you've got someone who might be having episodes of vasospastic angina, I'd be very cautious about the use of beta blockers. And given there are other anti-anginals available, I tend to use these first, such as calcium channel blockers, rather than using bisoprolol or similar. If you're unsure, you should take advice from a cardiologist. Lastly, pheochromocytoma. And I know we don't usually deal with pheochromocytoma patients, but you should be aware that if you use beta blockers on your own, you can get a hypertensive crisis, and they need to be used in conjunction with an alpha blocker. Of course, if you've got someone with a pheochromocytoma, you should definitely get them under the care of an endocrinologist pronto. Lastly, we're going to talk a bit about side effects and their management. One of the most common side effects of beta blocker is fatigue, and This unfortunately is often unavoidable. Those drugs I mentioned at the very beginning with the intrinsic sympathomimetic activity can be beneficial, but as I said, you'll probably find it difficult to get hold of them in most pharmacies, and I've never seen them used for this reason. There's a little bit of evidence that nebivolol is better tolerated, so you could consider that if your patients are really struggling with this. Another common side effect is nightmares and sleep disorders, and this is common with most beta blockers as they're lipid soluble and readily cross the blood-brain barrier. There's a few water-soluble hydrophilic beta blockers which don't cross the blood-brain barrier you can use instead, specifically atenolol, nadolol, or labetalol. Next, and again I mentioned this a couple of times, is this peripheral coldness or erectile dysfunction, which is a result of that unopposed alpha-adrenal receptor-mediated media vasoconstriction. Nebivolol, with its vasodilatory actions, can reduce incidence of these side effects. So if you've got someone struggling with these, that's generally where I'd go. Lastly, I very quickly want to talk about withdrawal effects. All beta blockers, when suddenly stopped, can cause some rebound symptoms. If someone's using them as an anti-anginal, this can be particularly severe. So if ever you've got someone on a beta blocker and you want to stop it, always wean it down slowly over the period of at least a few weeks, monitoring for any side effects. That concludes this video on beta blockers. I hope you found it helpful. The extensive references mentioned are all listed below. I would appreciate all comments, thoughts, or communications which could be added to the video or emailed to me at this address. Thank you once again for watching Primary Care Pharmacology, and I'll hopefully get another episode to you soon. Goodbye.